Hello, how are you?
We are fine, ma'am. Thank you, ma'am. Thank you for this cornea class has been long due, and there were
Yes, it was
message.
long overdue. Uh, okay. So just to let you know that I'm using two devices so that if one does any kind of problem, I can without wasting time, I can shift from the other one. Okay. So whenever you say, I will be ready.
Yes, ma'am. We can start now. Already 15 people have joined. I think we can start, please, ma'am.
Okay. So before we start, let me introduce myself. My name is Dr. Samina Bilal. I'm from Pakistan, Lahore. I have been affiliated with MVUPGO University since 2016. First as a student and later on as a teacher under guidance of Professor Motho and then Dr. Kaushik. My basic field of expertise is refractive surgery. I have been working for the last 17 years in a place which has all these facilities, state-of-the-art refractive facilities, but it's a basically private hospital where I get to see all kind of patients. However, when it comes to refractive surgery, that is my field of expertise. So today's exam is basically planned in a way, this is basically for anterior segment, and it is planned in a way where I will give you short scenarios and you have to practice how to reply in the exam. Okay. So without delay, let's start. So first question, who is the volunteer? Does anyone? Sorry.
Achha, anyone, please volunteer. This is just a mock exam. There is nothing to be
This is
afraid. Please volunteer, because if you do not try, you will not know what you do not know. And this is
yeah.
a mock. Yes, please.
This is very important because before we started, please
Dr.
tell me
Temina,
if you.
Dr. Temina, ma'am, you can take anybody's name. They can
Hmm.
tell first tell introduce themselves, and they'll just
Okay,
volunteer.
okay.
Please.
Ji, Assalamu alaikum. I'm Dr. Tamina, and I'll volunteer for this question.
Hello, Tamir.
Okay.
Please
How are
introduce.
you?
Please introduce.
I'm fine.
Ji.
Okay, Tamir. So, Tamira, the first question is: I read the scenario just like in exam, and you have to try. You will try to reply it in as concise possible way as is possible. Okay. So this
Okay.
is the picture of a 68 years old man who has this small swelling in the upper part of the conjunctiva since many years. The patient
Hmm.
doesn't have really any problem except that he feels some discomfort. So look at this
Hmm.
picture and tell me what you see and give your
Hmm.
diagnosis just based on this lesion you are seeing.
Okay. So, on this in this picture, I can see a small what appears to be a cystic swelling on the just above the superior limbus, and it is there are multiple vessels, probably conjunctival vessels on it, and it could be a glaucomatous. I mean a trabeculectomy bleb, and mm, in, in order to confirm my
Before that,
diagnosis, I sorry.
Tamina, before that, you give differential. This can be bleb, yes. Any other
Yes.
conjunctival lesion?
It could be a conjunctival cyst.
Yes.
Um, it could be I don't know if it's solid or it's cystic.
Mhm. But just on the picture, based on picture,
Okay,
can
based
you
on
see what kind of lesion is this? Is there does some specific name comes to your mind? This pink patch, do you call something common
it
pink patch?
it could be I mean it could be an ocular surface squamous neoplasia also.
Yes. And any
Um,
conjunctival
uh,
tumor?
it could be conjunctival conjunctival mm,
Okay.
papilloma.
So, so what investigations you will do and what are you trying to find out?
Um,
Any
So I want to know the etiology of the lesion, what actually it is.
So
So
let
what
me
I
tell you,
can.
he doesn't have any history of PRAP, and this patient
Right,
didn't do any kind of surgery. He's noticing
right,
this lesion for quite some time, and he is 68 years old man. So
right, right. So in that case, my primary differential would be ocular surface squamous neoplasia, and for that, I would like to, I can do an anterior segment OCT to see, or I can do an ultrasound biomicroscopy to see the extent of
I'm going to
the.
show you anterior segment OCT of this R. Now, what do you
Right.
see there, meaning?
Um, just a
First,
minute.
you have to identify the level of lesion. Okay, this is conjunctival lesion.
Right. So, hmm, um, so there
You're
is
right. You're
there
on
is
the right track.
right. So,
This is this lesion epithelial or subepithelial?
uh, honestly, I haven't
This
seen
is
many.
subepithelial. Okay,
Right.
so we go back to this.
Right.
This is, the differential you gave, all of these are possible, but in a person who is 68-year-old man,
Right.
in addition to all the things you said, one thing that is missing is lymphoma. Like you're thinking on the lines of tumor, but lymphoma or benign lymphoid
Right.
hyperplasia, that kind of thing is more important that you have to see. You have to rule out. Okay. So if you
Right.
do OCT, this is the
Right.
lesion. Okay. So
Mm-hmm.
now let me
Mm-hmm.
give you a hint because this is subepithelial lesion. Okay, so the
Subepithelial.
upper part is, this is, if you see closely, upper part is epithelium hyperreflective, and this is a subepithelial. This is Bowman clear white one, and this is a subepithelial layer. So
Oh,
that
okay.
picture
So this is
and this
the
OCT.
right. So this is probably then a conjunctival intraepithelial neoplasia. Um,
Mhm.
CIN,
Uh-huh.
and for that,
Why not
next in.
lymphoma? Why not? Actually, okay. So let's stop here for come out of examination mode. I'm just going to tell you that can be, but since it is conjunctival lesion, well defined history, uh, it's not a flat lesion; it's a nodular lesion, and this sign
Yes.
is
Yes.
this is basically
Favoring
lymphoid
lymphoma.
hyperplasia. Lymphoid
Yes.
hyperplasia. Okay, I'll
Yes.
later on show you a OSSN case as well. So this is
Right.
lymphoid hyperplasia. So
Right.
that we can move ahead. Okay.
Okay.
This
Okay.
why am I calling this? Because this is a conjunctival lesion. This is heterogeneous. You are seeing a heterogeneous lesion. Okay, these are hyperreflective areas. They are
Right.
surrounded by heterogeneous mass, and they are each hyperreflective area has hyperreflective margin. So basically, this is
Right.
benign lymphoid lymphoma. This can be based on this picture. I would
Right.
say this is either lymphoma or lymphoid hyperplasia. Okay, benign lymphoid hyperplasia. Now, next question
Okay.
is: we want to confirm whether it is lymphoid hyperplasia, lymphoma, or something else. Can you do another test? What next?
Um. Mhm. I can do a biopsy of the lesion.
Yes, we can.
Um. And
And
yes.
okay, so
And
one more thing.
impression. Right.
Mhm, mhm.
And impression cytology. I'm not sure whether impression cytology is also useful in this case.
We can do first for another question. Why am I calling it benign lymphoid hyperplasia and not lymphoma? Can you think of any difference on OCT between
Uh,
the two conditions? That is very well defined.
mm,
Okay, this can be lymphoma, this can be benign lymphoid hyperplasia. Lymphoma is
okay.
very well defined lesion. This is more homogeneous. Okay, so
Right.
next histopathology. Okay, so can you do you know what findings you can find on histopathology of lymphoma or benign lymphoid hyperplasia?
So there will be a lymphocytic infiltration, pleomorphic. I'm not
Yes,
sure, but there will be a
polyclonal. This will be flower type lesions. This is I'm just telling you like just to remember, polyclonal
Okay.
lymphoid cells with germinal center. They're making just small flowers everywhere, and there will be well
Okay.
defined vessels. Okay.
Right.
Okay,
Right.
so we can do immunochemistry as well to find out if it is B cell lymphoma or T cell lymphoma, because when we are planning the treatment, these things can come
Right.
handy. So based on this, we can say this is
Right.
benign lymphoid hyperplasia. Now, my question is, how will you treat this lesion, this person? What is the
Hmm.
treatment of benign lymphoid hyperplasia? If we have narrowed down diagnosis to here,
Right. So I will do an excision of the lesion.
that is
Not
the
sure.
gold standard. Yes, yes,
Right.
that is the gold standard. But
Right.
what else can you do if the patient is not? Basically, uh, resection is the ultimate treatment
Right.
we can do, but there are other some less invasive treatments as well. Can you think about that? Like patient is not willing for the surgery. Can you reduce the
Uh,
bulk of this by some other
um,
methods?
mm,
Oral
so
steroid.
oral steroid. Okay. Oral steroids. Oral
So we can
steroid.
do oral steroids if patient is not um, like cannot tolerate steroids. We can go for steroid sparing lesion, sparing medicines. If oral is contraindicated, we can give intralesional
Right.
steroids. There are some other medicines as well which we can give.
Right.
Let me write down. Yes. Okay, and we can do
Right.
cryotherapy or radiation therapy. Okay. So
Right.
last
Right.
question. So if this person is asymptomatic, you can give all these treatment. Like you may not go for a section. Will you
Hmm.
go for? Will you keep this person under observation? If yes, why?
Okay. Yes, I will keep the patient under observation because it might there might be it's a benign condition, so it will probably not recur. Then so I will
But it
not keep the
can.
patient.
But it can.
Uh,
But it
mm,
can
mm,
progress
mm.
to lymphoma at any time, right? Although rate
Right.
is less, but
Yes.
you have to keep under observation. So you will check the patient for 6 months
Right.
and for 5 years, and you will see
Okay.
for its progression and whatever test you can do. Okay.
Oh.
So
Okay.
it was
Okay. Thank you.
slightly like out box question. It's all right. Okay.
Yes.
So
Thank you so
now
much.
we have question number 2. Who will take this question?
Okay, I will take Dr. Asma Azhar. I'm from Lahore, Pakistan.
Hello, Asma.
Yeah,
Okay, Asma,
it is.
let me read this question to you. A
Yeah.
38-year-old woman presents with glare at night, and she got it checked from somewhere, and doctor said that you have cataract, but he also said that there is a very guarded prognosis of her cataract surgery. This is the picture you are seeing. Describe what you see and why did the doctor give a guarded prognosis, in your opinion?
Okay. So it's a colored photograph on this photograph of the eye showing mainly the cornea, and in the slit there is a slit which of the light which shows basically the nebular corneal opacity, which seems to be more in the visual center, and it's like sub seems to be subepithelial involving the stroma too. And rest the iris details are clear, and the pupil behind it seems to be round and constricted.
So lesion
And
is basically in the cornea. Okay.
yes, yes,
So,
lesion is in the
based on this picture, what do you think? This scenario, patient has glare at night, and this picture, what do you think this patient has?
the patient can have in my differentials,
Mhm.
the patient can have a dystrophy, the stromal
Mhm.
dystrophy. And the other possibility is if the endothelium, it can be like Fuchs also, Fuchs
Yes,
endothelial dystrophy.
yes,
And
it can be. So,
this,
what will you do? What investigation you will do to confirm your suspicion?
yeah,
You're
for
suspecting some
that,
corneal
first of all,
endothelial
yeah,
dystrophy. So, what investigation you will
specular microscopy, I will go
do?
for that.
Yeah. Yes,
And
yes.
yes, and
So
we can also
what significant what value on specular microscopy along with this picture, at this age group, what is the normal value and what will you will consider abnormal? Up till how?
Madam, I think at this age group, around if it is around 3,000 endothelial cells, that will be normal, or and below 2,000, 1,500 to 2,000, then there it can
More than 15, more than 1,500 is considered normal, around 40. Okay. So if the value is less than that, less than 1,000, that is abnormal. So the next question is, this patient has specular, this Fuchs, let's say we have narrowed it down to Fuchs endothelial dystrophy, and the patient has cataract. Now, what is the treatment plan for this?
This basically is the complaint of the patient is like glare, and on the base. So the glare can be because of this dystrophy, and it can also be because of the posterior subcapsular opacity. So we have to address the both the issues. For this, we need to check intraocular pressure also in this patient. And
so what is your, so the patient has, let's say, patient has significant cataract. So what treatment you will plan will be?
Yeah, if the patient has significant cataract, then if the cornea has like got less, quite less, we can plan for the triple procedure also, in which we can do the remove the cataract and do the keratoplasty at the same setting.
Okay. So which keratoplasty? What is the keratoplasty of choice for your patient?
It can be that a membrane endothelial strip keratoplasty, in which we can that endothelial we
right. If you are planning, so you're correct. So patient can have triple procedure if you think it is significant cataract. So what about refractive outcome of this patient, or otherwise outcome of this patient? The doctor has said that patient may not have very good result. Okay, so you have countered that by choosing for triple procedure. So in triple procedure, do you expect any kind of refractive error? And if yes, why?
Is a type of refractive error?
Like you will do triple procedure in this patient. Okay, you're planning that. Do you think the result will be absolutely fine by removing the epithelium? Is there any kind of refractive error, myopic shift, or hyperopic shift, or any problem in biometry? Do you expect?
Yes, if the patient will the vision the patient expectation, we should address it that this surgery is not like he should not expect the result to be quite clear, because the thing is, because the endothelial there is a compromise of endothelium, and they can be like I think there will be a because it's
But
endothelium,
Dr.
there is a thicker.
Look, you are replacing endothelium. Okay, so let's say in the long run, you have done a very successful keratoplasty and very good cataract surgery. Then patient should be, and everything goes well, then it should be all right. So why is that? So let me tell you, there will be hyperopic shift in this patient. There can be, despite doing everything right. Now, can you think of any reason in the biometry because of which we can have these refractive errors post-op?
Because the K reading will be challenging. There will be high K reading, and there will be underestimation of the corneal lens power. So that will result in the hypermetropic.
Why K readings are high in this patient? This is a simple.
Because of the
cornea is swollen.
Yeah,
cornea is swollen.
Yeah.
You're overestimating axial length, number one. Okay.
Yes.
So not K readings. There is error in axial length. This is one reason. There is another reason. When you add, when you do desmoid stripping endothelial keratoplasty, you are adding a tissue of stroma at the back of the cornea, right?
Yeah.
So can you think of any reason by adding that additional stroma? Can it cause, what kind of power will it add to the back side of the cornea? It will add negative power at the back wall of the cornea.
Yeah. So
you're getting me? So we are adding another additional piece of stroma at the back of the cornea. So we are adding a negative power. This can give positive shift, right?
Yes.
So
Yes,
you have to
madam.
take all these things into account. And third
Okay.
reason is initially when you have replaced the cornea, it will be thin from the middle and it will be thick from the periphery. So this abrupt change can sometimes can also called to hyper opaque shift. So you have to consult the patient that despite doing everything, these things can happen. Okay.
Fine.
Sometimes we do not have these fancy things, especially let's say we are not or you can say there is a small isolated area where there is lots of dystrophy and you don't want to go to the trouble of doing all the keratoplasty. So can you think of any other new procedure, new kind of keratoplasty for this patient in that scenario?
Madam, when the storm, you are saying that when the we just have to
I'm
no.
saying if you do not have graft,
Okay.
endothelial graft,
Okay.
and Hook's dystrophy is just involving a small part of the cornea, let's say in the center or in the peripheral part. There is another technology. I have shared this. This is dysmetorrhexis without endothelial keratoplasty. When Dr. Kaushik will share it on YouTube,
Okay.
you can read it. So what we do, if there is an isolated small part, you can just remove that. Just you can do dysmetorrhexis without implanting any kind of endothelial graft, and the surrounding endothelial cells, they will just take over this place. This is a new technology. I'm not sure how successful it is, but this is the new written in the paper, so you must know about that. So this is one of the methods. Okay, Asma?
Okay, and ma'am, there is another there are certain inhibitors are that is RHO kinase inhibitors. So is there any role of those also in that or not?
What about what?
In
To improve endothelium?
yeah, to it so they can endothelial cell proliferation. They help in that.
Look, we can do all these things, but the gold standard in this treatment, the gold standard will be triple procedure with this endothelial keratoplasty, either decimal stripping endothelial keratoplasty or endothelial TEK. So this is one of the procedures. So you can, if you are going without that, like you are performing cataract surgery and you're not going for graft, then you have to do anything you can do. I'm not very familiar about that, how effective that can be. So the gold standard is that, and this is just one of the technology you need to know. This is a newer one. It is written in many papers. Okay.
Okay. Thank you so much.
Now is question number 3. Who is going to
Madam,
take that?
I have a question. Sorry. We don't go for triple procedure in all cases of Fuchs. So how will we decide whether to just use the soft shell technique and low phaco power and do
Dr. Asma
that?
will
And
tell you. This is another question. Dr. Asma, how will you decide? What are the criteria which you have when
Madam,
you decide that this person needs to
yeah.
go for that?
First
In
criteria
preoperative.
visual acuity of the patient, how and secondly on the basis of specular microscopy, what will be the status of the configuration and the number of the endothelial cells.
How many cells? How many cells? If this is a cutoff value where you will say, no, this won't survive without keratoplasty.
I think less than 1,000.
Yes, and if your corneal thickness CCT pre-op
less
is
than
more than 640,
20.
then you
Okay.
have to go for triple procedure. Okay.
Yes. Okay.
So next question, who is going to take?
Yes, ma'am.
Okay.
Okay, I'm with you.
Okay. So first, introduce yourself.
I'm Dr. Mahmoud Zahran from Egypt.
Okay. Dr. Zahran, I'm going to read the scenario and you have to try to answer me in more concise way so that you can finish this answer in 5 to 6 minutes, okay, from exam point of view. So a 27-year-old man presents with sudden drop in vision while working on laptop, and patient admits that he may have rubbed the eye forcefully. This is the picture you're seeing. Based on this picture, what is your diagnosis? What do you see? And what is the reason for drop in vision in this patient?
I see it's anterior segment. I see it's anterior segment photo of the right eye showing mild subconjunctival hemorrhage or conjunctival congestion. Also, I see clear cornea, and I see a mild hyphema level in the anterior chamber.
So the drop in vision is because of?
Maybe it's
Hyphema.
not. Maybe it's related to history of trauma, or the patient may be on antiplatelet treatment or has any bleeding tendency.
Okay. So, based on this picture, you're seeing this picture. What grade of hyphema is this? How can we grade hyphema?
Grade hyphema about the level. If it's below than 1/3 of anterior chamber, it's grade 1. From 1/3 to 1/2, maybe grade 2. Above above 1/2, it's grade 3. If it's total hyphema, then it's grade 4. I see in this picture.
This
grade
picture
1.
is grade 1.
Grade
Perfect.
1.
So what? So you have. So what can be the causes? You said this can be because of trauma, and what else?
Possible causes of hyphema in general, it may be related to trauma, or patient on antiplatelet, or patient has bleeding tendency disease, or patient has refuses irides, maybe diabetic retinopathy or central retinal vein occlusion, and has refuses irides that may cause hyphema level in the anterior chamber.
Okay. So what investigations you will do? Any kind of ocular tumor you're thinking about which can cause, because young people don't usually bleed like this just on rubbing eye. So yes, you said trauma, it can be bleeding disorders. Any
Yes, it's
inter-
maybe
any
related to
tumor? Any tumor?
yes, it may be related to tumor. Yes.
Okay. So so what investigations? How will you confirm?
I see. I will need the investigations to the ocular surface or to the orbit, and the general investigation, systemic screening, for bleeding profile and antiplatelet drugs. And if he has diabetic history, also I will need investigations for the orbit, CT and the MRI, and also ocular ultrasound for the retinal condition if I can't has any view for fundus examination.
Why MRI? You're saying you will do MRI? Why is that?
If I suspecting a tumor compressing optic nerve or like this.
Okay.
Which
Any
optic,
tumor?
I don't know.
why is the tumor associated with this kind of the feature?
Yeah.
What?
Which tumor do you expect which will cause this kind of picture and which will be picked up by the MRI?
I don't know really.
No, think
Yes.
about it. Then don't say. Don't say about that. Okay.
If you don't know, then don't
and
say.
Then don't say that. You don't say that. Okay. So I
Yes,
was talking
okay.
about more about. So let's just pause here for a while. You have done very well so far. So this patient comes to you with this bleeding. How will you treat?
Okay. At first, I will measure the visual acuity. I will examine the fundus examination. I will examine the other eye as workup screening for the ocular condition of both eyes. Then I will start for the
Ocular
medical
condition?
treatment
Any
after.
tumor iris? Did you mention any tumor on the iris which can cause this kind of bleeding? Think about a young person, which any lesion on the cornea, on the iris, which can bleed. Juvenile xanthogranuloma.
Granuloma, yes.
This is the only condition, or melanoma, which can bleed. Otherwise, there is no. I can't think of any tumor in the brain which comes into the cornea unless there is neovascularization, and that is very far fetched. So stick to trauma. Sometimes forced rubbing. This can lead to that. There are some bleeding tendencies. People start taking some, they can have hemophilia or all these kind of problems, bleeding disorders, or taking any kind of medication which can lead to that. And there can be some tumor inside on the iris which can bleed. And on the top of the list is juvenile xanthogranuloma. Okay, so now when you're looking at the other eye, you are trying to find out the cause and you are trying to treat this hyphema. So if this is juvenile xanthogranuloma, let's say, how will you know? How will you rule out that this is not juvenile xanthogranuloma? You will look for lesion on the other eye or on the skin. Is it so?
Yes, I think I don't show.
Okay, so Okay, Dr. Zahran, you are giving what treatment you will give? Let's say it's a simple case of hyphema. At what stage you will decide that this hyphema has stayed
Okay,
for quite some time and
okay,
you need to go for surgical intervention?
okay. If it's simple case of hyphema after exclusion of any risk factors or any bleeding tendency or any systemic condition, I will start with conservative treatment, topical anti-glaucoma, topical steroid, and topical cycloplegic drops. And I will do surgical intervention, easy wash, or radiation aspiration in cases that if IOP is higher than 50 milli for 2 days, or above 35 milli for 7 days, or it's
For 5 days.
ball hyphema. What?
Okay, right. You're right.
Okay, or if there is any risk of corneal staining of blood.
Okay. So, Dr. Zahran, we have, in order to find out, rule out if it is any kind of tumor on the iris, what investigation you will do?
If I suspecting a tumor,
Yes. Iris tumor, any kind of iris tumor. What investigations you can do?
maybe anterior segment OCT, maybe UBM to exclude any invasion of the angle.
Okay, OCT. So you can do anterior segment OCT, which is more concise. So if this patient has juvenile xanthogranuloma, you find a lesion on OCT, will your treatment plan change? What will you do then? Do you think that bleeding, that granuloma, which is bleeding now, will it settle on its own? What are the chances? Will your treatment plan change if this patient has juvenile xanthogranuloma?
I didn't hear. Please repeat it again.
Will you, if the patient has juvenile xanthogranuloma, do you think your
Yes.
treatment plan will change? Like from conservative management to something else? Would you like to add
Yes,
something?
yes, because of risk of invasion of the angle, or infiltration or invasion causing epipulbar mass on the scleral outer coat.
Mhm. So what treatment you will give?
I don't know.
Okay, good. Okay, so if the patient has, this is a simple case, you can treat it conventional way, like by giving conservative management and just looking for resolution. But if it is a granuloma or some juvenile xanthogranuloma, it has a tendency of recurrent bleeds, which can lead to a lot of complications. There can be angle closure glaucoma, there can be new vascularization. So we have to treat it differently. So we have to suppress the tumor. So the treatment for juvenile xanthogranuloma is basically we give oral steroids. Oral steroids and for long time, and then we taper it off over 3 to 4 months period of time. Okay, Histamine. And in addition to that, you will do the treatment. And treatment of Hyphema is, so instead of just from topical, you are adding oral steroids and you are keeping an eye on blood pressure rise. And you will be like more vigilant in cleaning it so that it doesn't start causing complications. Okay.
Okay.
So now I'm going to ask next question. Who will volunteer?
Okay, I'm Dr. Arshi. I will volunteer.
Hello, Arshi. Okay, so I'm going to read a scenario and you have to answer me. So a 68-year-old woman comes with complaint of watering, foreign body sensation, photophobia, and discomfort on waking up in the morning. Okay, she is diabetic, she has arthritis, and she remembers that she did have trauma to the eye about this fingernail in the same eye 4 years ago, and the problem persists off and on since then.
Okay.
Based on this history, what do you think is causing this problem? Most probably.
Yeah, looks like she had a recurrent corneal erosion. Because she had a diabetes also, and she has arthritis. So diabetes itself can cause aesthetic cornea, and arthritis can cause severe dry eye. So if there was a trauma to the eye with the fingernail and it has not healed properly, there can be loose epithelium because of two coexisting condition. and can lead to the recurrent corneal erosion.
Good. So what is the treatment plan for this? Which sometimes giving one single diagnosis is the only way out, right? So you have done very good, very well, very well. Okay, so Arshi, what will be the treatment for this patient? How will you treat?
So the treatment is depending on that. We can first try with the with lubricants that can be every 1 hourly, 2 hourly, and we can try with cyclosporins, and we can put bandage contact lens, give some more extra vitamin containing lubricants, and try if it heals. If it doesn't heal, then there are certain interventions that we can do, invasive technique. First is we can do phototherapeutic keratectomy,
But
and
before that,
the
Arshi, let me stop you here. So you have
yeah,
given antibiotic,
yeah,
lubricant,
lubricants,
hyperosmotic agent,
bandage contact
and
lens,
oral.
bandage
Have you
contact
given
lens.
anything? Okay, so
Amniotic
anything.
membrane also we can try, amniotic membrane. Then there is something like, yeah.
But do you think a patient who comes with recurrent corneal erosion,
Yeah.
would you go to amniotic membrane so quickly? I don't think. Huh? So,
Okay.
so oral, anything oral, any oral thing you want to add which can improve this condition?
Yeah, steroids. But she's diabetic also. So, and she has arthritis also. So, steroids can be given under, and then
Doxycycline, you can try giving
under,
doxycycline.
yeah, doxycycline. Yes, yeah, that has anticollagenase activity. Yes, sure.
So this is first line treatment, okay? And you observe after
Yes.
some time. If it doesn't improve, what will be the next step? And patient wants you to do non-invasive things first.
Okay.
So what is the next treatment you will do?
We can try sometimes with hypertonic saline to make the cornea edges less swollen up. That can help in healing along with the bandage contact lens. And
Okay.
sometimes we give tears, or I mean the autologous blood, autologous serum, or sometimes we can ask a patient to put blood that has some derived growth factors.
Plasma, autologous plasma, you mean?
Autologous,
How does it
autologous
help?
plasma.
How
It
does
has
it help?
yeah, it has a growth factor in it, so
And
it
it
helps
promotes
in that way.
So if all these things fail, so then we have to go to surgical interventions. So
Yeah.
what is the next easiest step you will do?
Yeah, so there are two procedures. In one procedure, we can do this, through the
You said that
stromal
epithelial
punctures.
debridement.
Stromal punctures.
Stromal puncture.
Yeah.
Good. How
Stromal
does
punctures.
stromal puncture heal this condition? What it causes?
So actually, it causes fibrotic adhesions between the loose epithelium and the Bowman's membrane with the anterior stroma. So that if there was hemidesmosomes, problem or anything, so that helps in that way. It gives
And
fibrotic adhesions.
Other option?
Other
Debridement?
option is debridement. Yes, debridement. With sometimes it is done with the alcohol or just simple debridement, and put the bandage contact lens over it, so the new epithelium is better.
When you debride, would you like to do something else at that stage? Diamond bar, you're basically polishing off the superficial layer with diamond bar technique. Okay?
Yeah,
and if
yeah,
all
okay.
fail, or
Okay.
if you want to go for, like you have seen enough that patient is not improving, what is another treatment? What is another
Then we can do with the laser. We can do with the enzymer laser, PTK. Yeah, so we just debride the cornea, and with the enzymer laser, we can make some fibrotic adhesions. When it heals, it
so by
fibrotic.
PTK, which layer you are basically targeting? Like at what level? How will you decide that how much you have to apply enzymer laser?
Yeah, so actually, we take the at least 50 micron of the that is epithelium. So we'll go a little down to the Bowman's membrane.
You can either remove that. Basically, we have to target the Bowman's layer. So you can simply remove the epithelium, and now there is Bowman's layer. So top 10 to 20 micron, that will be enough to do that.
Okay. Okay. So, okay.
Very good. Well done. So we
Thank
are
you.
moving to the next question. Who will take this question? Any volunteer? Is any volunteer?
Good evening, ma'am. I'm Dr. Tanmay. Can I take this?
Yes, Tanmay. Okay,
Uh,
so let me read this question for you. Let me read the scenario. This is a young man had undergone third corneal graft. Okay, so describe this picture and tell us what is happening there.
Ma'am, since the individual has undergone corneal grafting for third time, so the
So first
chances of
describe the picture, what you are seeing.
there is a completely opacified cornea with the graft is in situ, and the graft host junction is appearing normal. There is no gaping in the graft host junction. There are superficial vascularization involving the mostly the superior part of the cornea, and
Uh-huh.
uh,
But graft host junction, don't you see these blood vessels throughout here?
yes, there are some blood vessels which are crossing the graft host junction and involving the graft tissue also. And I cannot comment on the deep vascularization, but
So
uh,
what is your diagnosis? What is this happening?
this is a graft failure, ma'am.
Yes. So can you tell the difference between graft rejection and graft failure?
Graft rejection occurs immediately after grafting and within 2 weeks, and commonly within 2 weeks, and that is a allergic reaction. And graft failure occurs in two forms. One is primary graft failure. One is secondary. Primary graft failure occurs immediately following the graft, and that is due to the donor tissue problems. And secondary graft failure occurs because of it can be because of graft rejection, and it can be other causes, and it is a later phenomenon. It occurs after, it may occur later.
So graft rejection, other than happening within 2 weeks, what is the basic pathology? What is happening and that it is causing graft rejection?
In graft rejection, basically the host, this is a foreign
Host
tissue.
immunological response
Yes,
to
ma'am.
foreign donor tissue, right?
Yes,
So
ma'am.
it's immunological response to the donor tissue. And so there will be all those signs. What are the signs of graft rejection?
We can have anterior chamber inflammation, cells flare, and in the graft tissue there will be the
That for those signs,
immune rejection lines, and one
KPs
part of the
and
graft
edema.
can be seen as opacified, and the other part clear, and the opacity gradually progressing and covering the whole graft. And
Okay,
keratic
so perfect, perfect. So this is the case of graft failure, right? So
yes, ma'am.
what next? What
So
can you do?
So, in this case, we have to, since this is the third time the individual has undergone corneal transplant, so again, doing a transplantation will again lead to, most probably it will lead to graft failure again. So, there is no point doing that. So, we'll check for the visual potential. We'll check for the posterior segment evaluation by ultrasound, and if the visual potential is there, uh, and if the other eye is also blind, and then we can go for keratoprosthesis in this patient.
Good, very good. So you will plan for keratoprosthesis for this patient, right? After
Yes,
checking everything from the backside. So
yes.
in keratoprosthesis, while planning for keratoprosthesis, in addition to seeing the visual potential, are there some other edit procedures you want to do along with that, and why?
Uh, Ma'am, during evaluation of keratoprosthesis, no, ma'am, I couldn't exactly
But
know
if you
what
okay,
exactly you want to.
so if you do keratoprosthesis and patient develops cataract later on, what will you do then? So you have to remove cataract. Okay.
Yes, so we have to remove that cataract,
Cataract.
and then
And also better if you remove if you make that like do posterior capsulotomy and optic capture technique, so that you don't have to go for you won't be able to do capsulotomy. So you will address that issue, number one. Secondly, there is another very important thing which is bound to happen after keratoprosthesis. Before that, you will answer this question. Once you're done with keratoprosthesis, okay? Do you
Yes.
put something on the cornea? Is there any special post-op care for keratoprosthesis?
Yes, we can. We put amniotic membrane can be put around to avoid adhesion, retroprosthetic membrane formation, and rejection of.
Why amniotic membrane? It will what if you obscure the view if you put amniotic membrane on that. We put bandage contact lens, right? On the
Yes,
keratoprosthesis.
yes, yes,
Okay.
ma'am. Following.
So you have done keratoprosthesis, you have applied contact lens. Why are you applying contact lens? To prevent melting, corneal melting. Okay. So what will be the treatment you will be giving? Post-op medicines, and that will give you the answer that what associated procedures you have to do.
Post-operatively, we have to prevent any dryness in the ocular surface or
yes,
any
inflammation. How will you?
inflammatory reaction and any infection.
Yes, but patient has undergone such a major procedure, and there will be inflammation. Would you give any kind of anti-inflammatory like steroids?
Yes, ma'am.
Patient needs long-term steroids. So if patient is using long-term steroids, what problems can happen?
There can be glaucoma, development of glaucoma.
Yes, there will be glaucoma. So there is almost always, because of that, at last coupled with inflammation. So we come back to the associated procedures. When you're doing keratoprosthesis,
yes,
you took care of cataract. What else? You will do glaucoma filtration procedure along with that.
Yes.
That is must. Okay. So
yes.
Sometimes some people advise that you can do pore vitrectomy, but still that can be left. But these three, iridoplasty, cataract removal, posterior capsule, like a slight, like make rexes in the posterior pole and optical capture.
Yes, ma'am.
Glaucoma filtration procedure, followed by this keratoprosthesis and contact lens on the cornea. Okay. So
yes.
Post-operative care we have just discussed. You will give antibiotic for steroid and antibiotic, lubricant, steroid. What else? Very important thing. Because you're anticipating increase in intraocular pressure, so you will go give anti-glaucoma medicines.
Yes.
Okay, so you will give anti-glaucoma. These are must. So despite everything, what complications we can have with keratoprosthesis?
The complications can be firstly extrusion or of the keratoprosthesis or retroprosthetic membrane formation or
yes.
Again infection and
there can be sterile vitritis. There can be, despite doing everything, there will be spike in IOP. There
yes.
can be retinal detachment. There can be vitreous hemorrhage. All these things can happen. Okay, so you have to take
yes.
care of as many things as possible while putting keratoprosthesis. So this is very important. When I went into the exam, I saw the keratoprosthesis for the first time in the exam. So it is one of probably very favorite topic of examiners. Okay.
Yes, ma'am.
Well done. Well done. So now
Thank
we are
you.
going to the next question. Okay. Who will take this question? Any volunteer? Please don't hesitate from taking question. The more you practice, the more your chances are.
Yes, ma'am, I would like to take. I'm Dr. Sania from Lahore.
Dr. Sania, I'm going to read this question for you. This is a 27-year-old man who developed sudden drop in vision. And patient admits that his vision wasn't very good to start with. So describe this picture and tell me what can be the cause of sudden drop in vision.
This is a colored photograph of anterior segment showing cornea, and over that cornea there is as you can see from the slit beam, that there is what you can say, there is this bulge on the cornea as this is seen by slit lamp, the slit beam, and this is an opaque one, and there is circumcorneal congestion also, and
So what is
this,
this?
this could be as they have mentioned, the vision was not already that good, so this could be an acute hydrops maybe, or in case of keratoconus, or maybe rarely keratoglobus also.
So you think
And
this is acute corneal hydrops, right?
yes.
So
You're right.
Dr. Sania, if similar picture is there in a child, like congenital child with this white kind of white opacity in the center, bulging.
Yes.
So what would the differential be?
Then the first differential can be ophthalmos related to glaucoma, or infantile glaucoma maybe, or maybe uh, not megalocornea. I think glaucoma, infantile glaucoma.
Okay, and
So basically, what is the pathology happening that has caused this sudden gushing of fluid into the cornea?
Okay. Mostly in keratoconus, this thing can happen. There is a sudden influx of the aqueous through the breaks in the descemet into the corneal layers. And because already they are compromised, so this sudden influx can cause pain, photophobia, and this corneal edema.
Good. I will recommend don't say keratoconus. Don't get stuck on keratoconus in the exam, right? Because
Okay.
if you read if you find out if you study the stats, that will show that more cases are of keratoglobus and other conditions. Only 2.4 to 3% are of keratoconus. You have to keep an open mind. So you can say there are breaks in the Bowman's layer, which led to sudden gushing of the fluid into the cornea, which led to edema, and because of that, that person had decrease in vision. Now, next question is, how will you confirm your diagnosis? What will you do?
Yeah, first take according to the history, and then maybe there will be history of any trauma or anything like trivial trauma, or you can say a patient might be doing some
No,
what
but
can I say?
Sania, okay, so
Yes.
whatever it is, what is the way forward? Now, what will you do? You will give some treatment, or you will do to do some investigation. What will you
Yes.
do?
First, because it's an emergency, so I will go for the treatment first. Later on, I'll plan for the investigation. On seeing the slit lamp, it can be seen as corneal edema, and so I will plan firstly this off hypertonic saline drops and ointment, and I will give pressure lowering maybe drops, and I can apply. If possible, I can apply any bandage contact lens over it or scleral patch, something like that. And and
Okay, Roxania, my question is, if you're looking at this picture, in
Mhm.
order to have for the treatment to work, you need to make the proper diagnosis, right? So although
Yes.
it's emergency, but you want it to heal. So is there any kind of, there are some basic investigations that you would like to do, which take just non-contact investigations.
Okay.
So on slit
Uh,
lamp, anything on slit lamp that you can do to find out what it is, which will then further help us in modifying our treatment. Any test?
on slit lamp, because it's opaque cornea, so we cannot see mostly, the features of any ectasia of the cornea.
You can do Seidel test. Okay. So what
Okay.
will Seidel test tell you?
The Seidel test will
If it is
guide about
positive,
it will
so
guide
that
about
there is,
penetration. Sorry.
if Seidel test is positive, it will show you what, that there is
Uh,
communication with the AC anterior
It's
chamber.
coming from the, if it is
So
positive, then could be aqueous coming from that.
anterior chamber. So what will you do? How will you modify your treatment? You will
Uh,
add aqueous suppressants, right?
okay. Yes.
So
Yes.
another thing, so just Look, corneal hydrop now, there are some non-contact investigators. First, you can look at the other eye and you can find out the pathology. It's
Very
keratoconus
important.
or globulus or whatever, okay? But
Yeah.
regarding this eye, there are some non-contact investigations which you can do and which
We
can
can
modify
go,
your treatment.
okay, we can go for a gentle UBM scan maybe for this eye.
If you have, yes, what will it show?
The UBM will show this this corneal details that mm,
Actually, what exact details you are trying to look at? Like, you know, this is hydrops, right? So by
yeah.
doing ultrasound biomicroscopy, or even better than that is OCT, you are basically trying to look at the break. It will show you in accuracy what kind of break it is, how large it is. So because when the tear is very large, it's not going to be it's not going to be healed just by topical medicine. So you go for anterior segment OCT. Okay.
Yes.
So
Okay.
when you go for look at this is OCT of acute corneal hydrops. Can you
Okay.
see, describe, what are you seeing?
Yeah, I can see that there is a large break in the descent and causing the influx of the maybe aqueous because it's a dark shadow.
This is
And
correct, right? And these are also fluid spaces. All these are fluid spaces. Okay. So
yes.
before that, you should also document corneal edema. You should do the grading as well. Any other investigation you can do, but that will come later on. So what is the management? Now tell me. This
Okay.
case and this
Conservative management, and because it's a huge hydrops, so probably firstly the conservative is the same like topical or hypertonic and maybe cycloplegics to relieve the pain, aqueous suppressants, and I can apply some this bandage contact lens
Okay.
patch over it.
Okay, so if you have given conservative treatment and patient is not healing, and you look at the OCT and you find a large tear, what are the surgical options you can have?
The surgical option, one of them is to put an air into the anterior chamber. Can be SF6, but not in expansile intracameral gas injection. Yes.
Gas, or you can give gas. How much percent? 20% SF6. Okay.
Yeah. Okay. Good.
And if you have done everything, patient has improved, but still it's not improving. What next?
If I've done everything,
Break is very large. You have tried to seal it with intracameral gas. It's not healing. Any other next? What is next in line treatment?
maybe we can go for some laser intervention.
What kind of laser intervention?
Laser like I don't know in hydro.
No. Then don't say that. Huh?
Sorry.
Don't say that. They don't know. So you then you will go for surgical options. You can go for keratoplasties. You have to remove this descent membrane. Okay.
Okay.
And finally, you can go for keratoplasty. So this is the way forward. You have to explain this way to the patient. So I would like to emphasize acute corneal hydrops is much more than just swollen cornea and giving this. So whenever you get a case, you should be methodic. Do tell that you will check to find out the pathology and investigate to find out the level of break, and so that you can treat it accordingly. There is another option. You can add plasma into the anterior chamber. In the first question we were asking about if you can, yes, we can add plasma 0.3 ml, which promotes endothelial healing. Okay, so we will go to the next question because we have lots of questions. Okay, so we have done this. So we move to the question number 7.
Thank you.
Any volunteers? Anyone?
Okay, I'm Dr. Arshi. If you want me back, I can.
Okay.
Try.
Okay, Arshi. So this patient underwent LASIK about 2 weeks ago, and after some initial deep recovery, the patient presents with blurred vision. Okay.
Yeah.
So you're seeing this picture. What do you see? And what do you think is the diagnosis? Differential diagnosis.
Yeah. So this picture shows a flap which is from the this is from the nasal. I am not able to judge whether it is right eye or left eye.
It's all right.
Uh,
So
so it looks like there is some DLK, some haziness is there over the cornea, which can be because of the DLK or because of the epithelial ingrowth. Looks like epithelial ingrowth coming from the flap side.
so what is the treatment? What will you do for this patient? Your
So
differential is it is DLK. What else?
yeah, diffuse lamellar keratitis, epithelial ingrowth, or there can be infection like keratitis, and yeah, keratitis that can be
So
infected
how
or
will you
diffuse.
control? Another very important thing you are missing out.
Okay.
So what will you do? Can you like do some
Yeah,
investigation to find out what it is?
yeah. Yes, so if I on the slit lamp examination also we can find it out what is the status, and then in the anterior segment OCT it can show at the flap level behind the flap what it is. Is it epithelial ingrowth? It will be visible.
This is
Okay.
the OCT of this patient. So what are you seeing at the interface? This area.
Yeah,
What is it?
yeah.
This is fluid at the interface.
Is it
This is
is
fluid.
it yeah,
So
there's
what can be the
cystic
cause of fluid?
fluid.
Let me give you a hint.
Maybe
After
yeah,
LASIK, you are giving
yeah.
post-op treatment, right? What treatment
Yes.
you give? What is the mainstay of treatment you are giving? Steroids
Post-LASIK, we give antibiotic, steroids,
and
and lubricants.
steroids. So any problem with steroids?
Yeah.
Can it cause
Uh,
raised IOP?
yes, it can cause raised
It can.
IOP and it can cause water retention. Yes.
Since we cannot discriminate, we cannot do tonometry and all these will not be very reliable in post-LASIK period, immediate post-op
Yeah.
period.
Yeah.
You have to differentiate if it is raised IOP or if it is DLK, because treatment is totally opposite, right?
Yeah. Yeah. Sure.
In
Sure.
DLK, you increase steroids. In
Yes.
steroid-induced IOP, you have to
Yeah.
reduce and you have to give anti-glaucoma medicine. This is the important
Exactly.
time I
Yes.
want to show this scenario. So you look at
Yes.
that and remember two things. Do OCT,
Yes.
use technology, and now you will say that this is because of high IOP and you can treat by
Steroid
giving
induced.
reducing
Yes.
steroids instead of increasing,
Yes.
and it will settle
Yes.
down. Okay.
Yeah. Yes. Yes.
Good.
Yes.
So we are
Yes.
going to question number 8. Any volunteer? Anyone can take that. No issues. Tamina, you can take that. If anyone
I will take it, Ji.
Okay. Okay, Tamina, this 26-year-old girl has high myopia of minus 18 diopters in the both eye,
Right.
but her best corrected visual acuity is 6/9. That patient desperately wants refractive procedure. What
Right.
treatment you will offer and give its pros and cons?
Okay, so the various options available for this patient, LASIK is obviously not an option because it corrects up to 14 diopters, 12 to 14 diopters of myopia. So the various patient has to undergo a surgery if she wants her refractive correction done. What I can offer her is a clear lens exchange, which with the removal of her natural lens with the insertion of another IOL, or a phakic implantable Collamer lens inserted behind the iris. And I can also offer her this smile procedure, small incision lenticule extraction.
But SMILE cannot correct up till minus 18. Even LASIK cannot correct to minus 14. So two viable options are either clear lens extraction with IOL implantation or phakic IOL. Will you
Right.
advise clear lens extraction? If you advise, what are its pros and cons? What problems you can tell, and which one will you prefer with your
Right.
treatment option?
So, clear lens extraction carries the risk of retinal detachment in this patient because she is a very high myope. And so I will I can offer her prophylactic barrage laser before going for clear lens extraction. And as regards the implantable columnar lens, it can cause uveitis, pupillary block, endothelial cell loss, and it can
But
also
you have
cause
to give
retinal
an option. So let's say if the patient, after hearing your all these things, patient opts for phakic IOL, okay?
Right.
So for phakic IOLs, is there special workup you have to do before you can say that this patient is the right candidate for phakic IOL? What is
I
the
am not.
pre-operative assessment? Anyone else wants to take?
AC
Anyone, if
dips.
anyone wants to chip in?
White to white pressure,
dips.
white to white line is important.
I think for phakic IOL, we need to know the anterior chamber depth and the effective lens positioning. So this
In
is
addition to other things, it's a refractive procedure, right? Just like every refractive procedure, you will check everything. Cornea, patient has high myopia, you will check IOP and consider that patient may have be later on spheroid responder. Check IOP and document that. You will look at the retina, and after that, now you are coming to the IOL. Now, what will you do? Yes, whoever said anterior chamber depth. What is the reason for that?
because anterior chamber depth is very important, because if while doing the calculating the power of the lens that is to be implanted, we need there in the fourth generation formulas, we need to know the anterior chamber depth. And
that is one of the reason. But before that, anterior chamber depth and
There
white
has
to
to
white.
be adequate
What is
space
the
in the
significance?
anterior chamber.
It can
It should
lead
be.
to glaucoma if
So anterior chamber depth, there has to be a certain cutoff limit. Under that anterior chamber depth, you cannot use phakic IOL. What is that cutoff limit? First, tell me that. How much should be anterior chamber depth? 2.8, less than 2.8.
Above 2.8.
2.8, yes. So why is anterior chamber depth important? Let me rephrase. Okay, so I'll ask you the next question and you will automatically know its answer. You have different sizes of phakic IOL, okay? What size of phakic IOL you will choose, and based on what criteria? Okay, let me
Based
give a
on the
hint.
anterior chamber depth.
white to white line.
White to white.
Yeah.
Okay, so phakic IOLs, their size is 250 microns to 750 microns. You have to choose anywhere between this according to the shape of the eye. Okay, so anterior chamber depth, white to white, you have to measure that through proper, like through pentagram as well as by manually. Difference should not be more than 2 millimeters. Discrepancy should not be more than that. Okay. So second thing is anterior chamber depth, because this phakic IOL that will basically vault over your crystalline lens. There is slight space between that. So if you are choosing very large phakic IOL, that will decompensate your part, right?
Yeah.
So your anterior chamber depth, more significant thing, always tell about more significant things. So anterior chamber depth is important because you have to choose the right size. Measure white to white and anterior chamber depth and then choose the right size. This is very important. Okay. So any operative precaution you can take to ensure good results.
Is this called vaulting of the lens?
The lens is shaped this way. Yes, this is called vaulting of the lens. The lens is shaped this way. There is a slight space between natural crystalline lens and it is basically vaulting over that natural crystalline lens. It's not touching it. There is space so that aqueous can freely move between them. Okay.
Yeah.
And there is so yes. So you cannot choose very large or very small. You have to choose a size according to the white to white and anterior chamber depth. So operative precautions which can ensure good results, that you don't touch the cornea, you don't touch the crystalline lens so that it doesn't develop cataract, right?
Yeah.
Can you think of any advantage over excimer or clear lens extraction of phakic IOL?
Yeah, it can. We can correct lots of yani big refractive error, and if there's any keratoconus also, then in which we cannot do any refractive lasers. In this, we can do ICL, which can be a toric ICL also.
Okay, so there are, because they are available in many options, Toric and all these options.
Yes.
Despite
Yes.
so, what are the complications we can expect with these phakic IOLs?
The precautions will be the same as it happens with the cataract surgery. Like, since we are opening the anterior chamber, it can lead to, we have a,
But
risk
there
of
are some
infections,
specific complications.
endophthalmitis, glaucoma. Yeah, pupil block.
There are some specific problems. There is always initial spike in IOP, but it settles down. So you have to be like on watch for that. You give anti-glaucoma
Yes,
medicines, okay?
yes,
So
yes,
sometimes there can be, but rest of the complications are same as cataract surgery, but there can be corneal
yeah,
decompensation if you have done
yeah,
excessive manipulation
decomposition.
during the surgery or for whatever
Yeah,
reasons. So you have to be
yeah,
careful. Sometimes you can even go for keratoplastic if we are not very careful, okay? Good.
yeah,
So
yeah.
we have covered phakic IOS. Dr. Kaushik, you can tell us when to stop because I have many questions. So I think we should do a few more questions.
Madam, I have a
Okay.
question. What degree of myopia does the lenticule extraction correct?
Smile.
Yes.
Uh, Look, it depends on the size of on the thickness of
Corneal
your
thickness.
cornea.
Corneal.
So it varies on
Right.
person
Yeah,
to person. I don't think it can correct more than minus 8.
Okay.
yeah,
Okay.
It's,
Thank you.
huh? So we will
yeah.
leave.
And astigmatism
Huh?
also, I think -3 astigmatism.
Yes. So we will leave this. We are going to this question number 10. Any volunteer? Do you want to take this question?
Dr. Sania.
Okay, Dr. Sania. So a 70-year-old man is being operated for cataract surgery, and you notice zonular dehiscence during the procedure. This is a picture. First, tell me what can be the cause of zonular dehiscence in this patient, and then
Okay.
tell what are yes, and what are the per-operative signs that tell you that this patient has probably zonular dehiscence.
Okay, this is an anterior segment picture of maybe left eye showing cornea, which is clear, and there is mid dilated pupil. And in the pupil, I can see there is this some flaky anterior capsule round on the in the pupillary margin. I can see some flakes on the anterior lens capsule. And this could be most probably pseudo exfoliation.
So, what are per-operative signs that show this person has?
Operative signs can be if if we enter into the anterior chamber, initially maybe we can see an Emsler sign, that is can be bleeding into the anterior chamber whenever we enter the anterior chamber, or there can be phacodonesis or iris tremulismus, because the iris is also not will also not dilate fully. So
There is fluctuation.
Doctor, you think that bleeding from the anterior angle is a sign of this zonular dehiscence?
sorry, sir, I can see what?
No, you said that if there is a bleeding from the angle, then ampler sign is a sign of zonular dehiscence. So from where did you read?
How will I treat?
Glaucomatous cyclitis crisis. Fuchs uveitis.
You said it has no ampler has no relation with you, with the zonular dehiscence. So please do not mention this here. Yes. Hello.
Yes, sorry.
So this has no relation with this thing. The ampler sign has no relation with the zonular dehiscence. So do not mention it here.
Okay.
Yes. So this was totally, and if you say that, this will be wrong. They'll take you to another area which you do not know.
Okay. Okay. So there can be zonular due to zonular there can be lens phacodonesis, or the pupil might not dilate fully. So we might for the surgery might need this manually dilate the pupil, maybe with some iris hooks or something like that. And because there is dehiscence, we can also plan pre-operatively for cataract surgery to use these CTR ring, capsular
Okay, so
tension.
when you notice zonular dehiscence, you will assess zonular, the extent of zonular dehiscence, number one, and then you will
Yes.
plan the next thing, right? So you said
Yes.
you will use capsular tension devices, CTR. What before that, while you are doing rexes, anything you will take care to ensure that you can use the right amount, like in the size of rexes, what will you keep? Any consideration about that?
Yes.
Rexes should not be very small. It should be 5
It
to
should be
5.5 millimeter.
adequate. Okay,
Okay.
5 to 5
So,
millimeter, yes.
so what should be the size of CTR you will use? It should be bigger or smaller than your bag,
It should be a slight bigger than what
your capsular bag, right?
that capsule.
Your
Yes.
bag, because you're going to support that. So since you have noticed this dehiscence during the procedure, so you may not be able to have time to like measure everything. So what size you will use for the procedure? Your assistant offers you 2-3 CTRs.
Mm-hmm.
You will choose the biggest possible one. Okay. So
Yes.
at what stage in during the surgery you will use these capsular tension ring, before PECO or after that? What is your plan?
What I think is it should be used after the removal of the lens. But if the dehiscence is not allowing the phaco to be done easily, like if there is a lot of dehiscence, then we can apply it before lens removal also, phaco.
Okay. And if despite using CTR, it's not stable, what else you can do? Next thing.
We can use that soft shell technique.
What? Yes, Tanya.
We can
You
use
can use
that.
capsular hooks, right? You can give
Yes.
extra force with capsular hooks, and you can continue that. So, any contraindication for the use of CTR during the procedure?
Contraindication. If
there is PT
rent.
If there is PT rent, then you won't do that. Okay.
Okay. Yes.
So, one last question: will you modify IOL power when you are using CTR, or when there is zonular dehiscence, for good outcome?
Yeah.
If there is dehiscence, then I can put if there is not much support, then I can put the IOL in the sulcus also.
But if I have to put IOL in the sulcus, then there is no point in using CTRs, because the whole purpose was we want to implant the lens into the IOL. You can do everything. So if you're planning to put IOL into the bag, you have stabilized the bag enough with the help of CTRs. Any modification? Basically, there will be posterior. You are basically, because of zonular dehiscence, there will be posterior tilt of IOLs. Okay, so you increase the power, slight increase in power of the IOL. That is required.
Okay.
Thank you.
And 3-piece, ma'am, to be added, right? 3-piece to be used. We can use one piece, or 3 pieces needed.
3-piece is better.
Is better.
Okay.
Yes.
So this is another question. This is a very good question again. So this person at 25 years old, who anyone can take up questions. Okay. So I think we will do this and one another question, and then we will stop it. So a 25-year-old man underwent PRK about 3 months ago.
Yeah.
His pre-examer visual acuity was very good. It was 6/6 with 4.5, minus 4.5, and 5.5 on the left side, 6/6 vision. His corneal thickness was 490 microns. Now the vision has reduced to 618 and 624 respectively in the right and left eye. So what describe what you see and what is the cause of this. What is happening here basically on the cornea?
Ectasia.
Yes.
This is corneal haze.
Post-LASIK ectasia.
No, it's just
This
corneal
is post-PRK, 3 months
corneal
post-PRK.
Corneal stromal haze.
Corneal stromal haze post PRK.
Is it okay? So what is the treatment? What will you do? First, tell me what is the factor in the history which you think may have contributed to this corneal haze? I would call it scarring, rather. Thin cornea,
Close.
right?
and also improper steroid use.
So how can you? So what next? How will you further treat this patient?
I'll start
Any
by
investigation?
steroids.
Because there is a scarring in the cornea, so we can go for like PTK, phototherapeutic keratectomy, and if there is corneal thickness allows us, then we can redo the PRK after
So
a
how
gap
will you
of
find out?
yeah.
Dr. Asma,
we'll-
how will
yeah,
you decide that this cornea, this scarring, the level of scarring, how much stroma is available? So what investigation you will do?
I will do anterior segment OCT and the pentacam.
So here is the pentacam, OCT. This one, middle one, is the stage here. So what do you see? What part of cornea is involving this scarring?
In the middle picture, I can see that this is maybe the anterior stroma is involved because there's a more hyperreflective areas in the anterior stroma. And in the middle picture, it is so, but in the right hand, extreme right hand, the whole stroma has been hyperreflective. So
Basically, we will stick to this one, okay? So in PTK, you are planning to do PTK, okay? So how much, what kind of opacity you can treat with PTK? How deep it should be? How much? So what is the criteria to choose that?
I mean, I think it should should not be below the Bowman's membrane. It should involve the corneal epithelium and the Bowman's membrane.
Haze, that can be treated with steroid. You have to treat stromal. PTK
Mitomycin.
you can prevent it by using MMC operatively, right?
Okay.
Yes.
Number 2, now this scarring has developed. It's been 3 months. You can give a short course of steroids. If it improves, all right. But you have to investigate with OCT to see how deep it is. You cannot treat very deeply. It has to be in the upper 1/3 of the cornea. Okay. So 1/3 deeper tissue. This is involving. In fact, this is showing that it is 1/3 superficial, involving one superficial 1/3. So it's not responding to the treatment. We can do PTK, making sure that our corneal thickness doesn't go below 250 microns. I would say it shouldn't go below 300 microns. So then you can plan PTK. Okay. So be methodical. So once you see, first discriminate between corneal haze and stromal scarring, give trial of steroid, and then confirm with OCT. Pentacam you have to do. You were right in saying that later on there will be by PTK. Okay, so once we do PTK, what kind of refractive shift it causes? PTK.
Hyperopic.
Anyone can tell.
Hypermetropic shift, man.
It will go how much? How much removing of how much stroma will cause how much shift?
It causes one diopter change with 50 micron. I'm not
50
sure.
microns, 0.50, 0.75. So you will do pentacam so that later on you can plan further corrective surgery later on. Okay?
Fine.
Okay, so this question is very important. I would say you should do it. Okay?
Yes, Dr. I can.
Who will take Heba? Heba, will you take this question?
Yes.
Okay. So a 45-year-old man, are you ready?
Yes, I'm ready.
Okay, so a 45-year-old man is wearing rigid gas permeable contact lenses for last 15 years. Okay. Now he has developed cataract and wants best refractive outcome out of his surgery. His documents show that his best corrected visual acuity was 636 in the right eye, which has dropped to 6/60 over last few years, and 618 in the left eye, which has reduced to 624. So, based on this scenario, what do you think? What is the problem in this patient, and how will you proceed?
Okay, so this patient is keratoconus. So he will have a regular corneal surface. So there is a problem in K readings.
Are you saying
And also,
that person probably has keratoconus, RGP? He's wearing RGPs, so he has some corneal ectatic problems, right?
Yeah.
yes.
Is it so? Okay, so
So
okay,
he has a regular corneal surface. So it's there is a problem in K readings with this patient, and also there will be changes in the measures due to rigid contact lens. So I have to discontinue wearing of contact lens before any investigations for
Very
at
good.
least months.
Yes.
Good. Okay, so patient comes back after a few months, weaning off after 1 month. So what next? Now, what investigations you will do? Like you're planning cataract surgery in a patient who has contact lens. You have done the first step, like you have weaned that person off of contact lenses so that K readings are reliable. So now, what investigation you will do?
Pentacam.
And why? Yes, pentacam. Why? What you are trying to do by doing pentacam?
And I'll also do a pentacam for the other eye.
So you want to see the staging of keratoconus, as well as you want to use these readings for the while doing biometry. So, in a patient with keratoconus, what are the problems you can have? What challenges you have during surgery, before surgery, in a cataract surgery? What challenges you will have, and how will you overcome that?
I think yeah, there is problem in IOL power calculation and also in axial lens calculation. So I think I have to do also a scan and take an average measurement for axial lens.
Basic problem is with axial lens or with K readings? You tell me.
K reading.
With K readings, more problem, because axial lens you can take with any technology. So what are the problems with K readings, and why they are not reliable in a patient with keratoconus while doing biometry by conventional methods?
He was using RGP contact lens that have changed the contour of the cornea, so the K reading won't be reliable. There is astigmatism, which is irregular also. So
yeah, because in the
Toric
K
IOL
reading,
will be better for him.
Inch between the interior curvature and the posterior curvature marked in the keratoconus.
Very important. That is very important. Even in subtle, look, when keratoconus is advanced, then there will be many problems. But even in subtle keratoconus or early keratoconus, anterior posterior ratio, that will be altered. Most of the formulas are using the ratio between anterior and posterior wall of the cornea. So that will be altered. That is one of the problem. Number two, patient has keratoconus, inability to fixate. So you are basically measuring the peripheral part of the cornea. That will give false K readings. Then cornea is very thin, very steep in the near middle area, and there is abrupt steepening from the middle to the periphery. This also gives falsely high K readings, and there is irregular astigmatism. So what can we do to overcome these? So you can do pentacam, and you can use the best possible K reading, aligning with the pupillary area. and you can do the axial length as well, right? Right, Heba?
Yes, right.
Okay, so
Ma'am,
you
there
have
are
done
some formulas which can take out without the K reading. We can do that is like a Hage's formula, which are used in the refractive surgical patients, post-refractive laser patients. We use those formulas that can be used in these keratoconus patients or not.
you can look K readings. You have to take K readings into the account because even if I would say even if you are seeing the pentacam and you are using the K readings, patient you have to look where patient's pupil is and from where actually patient is seeing. So you have to carefully monitor that area. So K readings taking into account is more important. So best formulas. Next, this was my next question. What is okay? So this is just I'm showing. You said we will do pentacam. So can you see? Tehmina was very worried about like inability to detect. Dr. Tehmina, can you see this is keratoconus? In the exam, you won't have lots of time. So this is keratoconus, typical keratoconus. Okay, so if you look closely, you are seeing these red dots. Okay, now look at these red dots, you will find very high K readings. You don't even have to look here. Then you corresponding to that area, you will see thinning area. So this is keratoconus. Okay, so we are moving to next. So we are talking about biometry. So what formulas are best? So I would say we should take K readings. That will give us a better result. So what formulas are better? I would say Barrett 2 universal formula is better.
Hage's formula.
Barrett 2K.
Even SRK2 is also good. Okay.
Yes.
So what type of IOL, Heba? What type of IOL you will choose for this patient? Because patient is very eager for refractive outcomes. So what IOL you will advise or will not advise at all?
I'll put monofocal IOL. I'll not recommend the multifocal or toric IOL for this patient.
Toric IOL is
monofocal toric IOL can be used. Monofocal toric IOL.
You can use toric IOL. Only multifocal IOL is contraindicated because patient won't tolerate that. Okay.
Yeah.
Monofocal and toric IOL you can overcome. Results may not be very accurate, but you can use toric IOL. Okay. So your aim refractive outcome. What should you do? What should you aim? Refractive error. Yes, and if patient says, since the patient is worried about refractive outcome, what can you do on that?
Sorry, what's the
outcome? A little myopic. Keep it a little myopic.
I can't hear you, Dr. Samina. Another one is talking. I can't hear you well.
We can use we can aim for the clear vision, and after the refractive surgery, we can use the RG these contact lenses.
RGP, because patient has been wearing. So you have to be very clear. Tell the patient that result, regardless of whatever we do, results cannot. There will be error because of all those reasons we have discussed. And we will aim for slight myopic correction, and for rest of the time, for the rest of correction, patient can use RGPs or glasses. And please do not say we cannot do excimer laser in a patient of keratoconus. Okay, so this is basically you don't have to say. Good.
Then one thing more, can we use ICL implantable? Not ICL. This Intacs in the keratoconus patient and bring the cone in the center.
Why
and
not?
Then do the
later on, this is step-by-step approach. Step-by-step approach. Okay. First, you will try to do as good as you can do in the cataract surgery. Okay. So you are doing your best to do the best biometry. You are taking care. So don't ignore pentacam. Don't proceed without that. Okay. You can do toric IOL. After that, you see if the patient has reasonable vision with glasses or with that, you can advise that. If you want to go further ahead and you think that by giving some support to that cone, you can use inlays because these days that tunnels are made through femtosecond laser. So you can do that, but then again they have their own problems. So what are the problems you can have with corneal inlays?
Extrusion and intrusion of the ice. this one intact. But ma'am, this collagen rings which has come nowadays,
They are
it's
very
good.
good.
I think that intrusion is
They're
not
well
happening in
tolerated.
that.
So you can do that. You can do that. Why
Yeah.
not? Why not?
Yeah.
So you can mention that. So this
Yeah.
question was asked by one of our candidates in last exam. So this, I think, I thought you should do that. So anyone who will take this question, anyone can take.
Yes.
I will take it, madam.
Okay. So what are the differences between optical and ultrasound biometry?
Right. So optical biometry is a non-contact biometry which uses infrared light for measuring the axial length, whereas ultrasound is a contact method which uses sound waves, and optical biometry is more accurate as compared to the ultrasound. There are less chances of error with optical as compared to the ultrasound.
Why? Why is that? Why is it more
Because
accurate?
because in ultrasound, you can iatrogenically press on the eye and you can miscalculate the axial length.
This is one of the reasons. Another reason, optical biometry. What does it measure? Which visual axis it measures?
Visual
It measures
axis.
visual axis, okay? And the other
Right.
one that measures anatomical axis.
Anatomical axis, right.
So what do you think? Is this an advantage or disadvantage? Use measuring visual axis or anatomical axis. So what is the problem with measuring anatomical axis, and what patients will not be suitable with ultrasound biometry?
Positive and negative angle kappa patients won't be good with ultrasound biometry. Visual axis is mostly needed for in the optical.
For optical, we need visual axis. For ultrasound biometry, we do not use. We are using basically anatomical axis. Okay.
Yeah.
So
yeah.
So is it an advantage or disadvantage? In what condition, or let me rephrase, in what conditions ultrasound biometry will not be very suitable and won't give very good results?
In staphyloма,
Yes, in posterior staphylomas, and if axial length is more than 26, this won't work. Okay.
This will not work in US. I mean, this will not work
because
in ultrasound.
Look, patient sees through the visual axis.
Through the
we
visual
are going
axis.
to visual axis. We need visual measurement of visual axis. So optical optical biometry, this is more accurate because these are infrared lights. They are more accurate. They have better penetration. But when you are measuring visual anatomical axis, so in staphylomas, you are actually overestimating the axial length. We need visual axis, so there will be error in the biometry. But there are some conditions in which optical biometry is not very suitable. Can you think of any condition?
Dense cataract. Very dense cataract. Not to axial length with the optical.
Cannot focus properly. Okay, so there you will go for that. Perfect.
Ma'am, what about this positive and negative angles which happens in pseudo-esotropia and pseudo-exotropia? Then then that way the optical will be better, right? Because we'll be doing
optical
the visual.
Definitely better because patient will fixate in that direction. And patient will be seeing through that. So that shouldn't be a problem. Okay.
Yeah. Okay.
So this is who wants to take this question? Anyone? This is very easy.
I'll do.
Okay. So a patient underwent refractive surgical procedure in 1997 and has developed cataract now. She is wearing hyperopic glasses. Okay. So here is a picture. What procedure is done?
So this is called with the spokes wheel. 1 minute.
This is RK, basically radial keratotomy, right?
Yes, RK. Yes, ma'am. Yes.
Radial keratotomy has been done.
It is radial keratotomy. Yes, ma'am. Yes.
Radial keratotomy.
So that is the reason she is wearing hyperopic glasses. So what we can do is we can do the lasso sutures. in
Uh-huh.
this to correct the astigmatism. And yeah, and we can do the cataract surgery, but before that we can do the lasso sutures.
Before that, anything in the history you would like to ask? Okay, so you want to do LASIK, you want to do sutures, right?
Lasso sutures, yes.
In which area you will apply those sutures? How will you
Yeah,
where to put that?
yeah, we'll do 2 rings of it. So around in the mid periphery.
At what location? Like this is a picture in front of you. Okay. So
Yeah.
you said you will apply sutures over here. In which area?
Yes.
Where? How will you decide where to put the suture? Before that, you need to analyze something before deciding that you want to put sutures or not, right?
Yeah, yeah.
Is it so? So what is that? You want to see the integrity of these.
We need to do
integrate.
pentacam in that.
We need to do what?
Pentacam.
ASOCT. Yes, look, before pentacam, you are looking this patient on the slit lamp examination. You can see gaping of the vessel, gaping of the incision. You can analyze because these cuts are how much deep? These cuts, how much stroma do they cut?
Anterior to 2/3.
90% of the cornea. These cuts are 90%, involving 90% of the cornea. Okay. So just on slit lamp examination, you can see the gaping ones. If you see any gaping incision, you will apply sutures over there. Okay. So it's not something random. You have to see there. Okay. So one step you said that you look for integrity of the and you address that issue as well. Now, anything important in the history? Okay, so now patient has cataract, okay, and you decide that despite putting sutures, vision is not correct and there is no other choice, you have to go for the cataract surgery. What important things, what problems you can have in this patient?
Starburst, glare, that will exist even after the cataract surgery. And the full correction, should not be expected by the patient.
Why is that? Why is that?
Will need because of the astigmatism that has been created by this.
But we are trying to, but we are let's say astigmatism is not, let's just for the sake of discussion, astigmatism is not very high, and you see that these are stable incisions. So you are planning the cataract surgery, okay? So if you're planning the cataract surgery, what problems you can have in biometry? One, you said you will have difficulty in having reading K values. Did you say that?
Yes, yes. So? K values
so how
is
will
difficult.
You overcome that? So basically, biometry is an issue in this case.
Biometry is difficult. Yes,
so
optical biometry is very difficult. For that, we will do the topography differently.
Okay.
Pentacam can be done.
For
and true K.
Yes, you will find. Yes.
True K has to be taken out, and then.
And you can take axial length because that is not an issue. And look, in this case, there is another thing. Anything in the history you want to find out? Patient complaint.
Any collagen vascular disease was there or like that?
No.
So that
no. I just want to stick here. Aswa, you want to say something?
Yeah. I would like that if he has got the pre-PRK, this RK K reading and refractive status available with this patient, that will enable us to calculate now the exact K values.
So what is the significance of pre-RK values? Why are you demanding to see those?
Because so that I can now I will do the refraction again, and then I will subtract algebraically from that. There are some certain formulas, and that can help me to find out the exact K readings and the exact power of the lens.
But I have pentacam and I am taking 2K values, then why am I so worried about what was the situation before RK? There has to be some other reason for that, you know.
It can be because of because RK has got flattening of the cornea, which is
Yes,
taking the patient towards the hyperopic shift. So if we
yes.
know pre RK, what was his glasses, what was his K reading, then and what was the myopia or hypermetropia, it will
Look,
help
Archie,
us in
your line of
calculating the
thinking
eye.
is correct. I just want you to refine a little bit here. So patient
Yeah.
has flat cornea, okay?
Okay.
Because of RK.
Yeah.
So
Yeah.
we want RK value, pre-RK values. They are for another reason, and it's not about K values. In the biometry, what are the things you want to find out? Number one is the exact power, K readings, and another thing which can alter the number of the
Effective lens position.
effective lens position. So you want to measure that, find out the exact effective lens position. Now correlate this thing and tell me,
Ma'am, I couldn't hear
why
you.
are
What
PRK
what
values
position, ma'am?
important?
Ma'am, what position? I couldn't hear. What position?
Effective lens position. When
Okay.
RK is done,
Yeah.
actually, can you hear me? When you
Yes,
have done
ma'am.
RK, you are assuming that chamber is shallow. You are
Yeah.
measuring
Okay.
it's shallow, okay? So
Okay.
it's not exactly, but you're finding it shallow. So by
Okay.
finding pre-RK value, this method Asma told us, that is
Yeah.
basically to find out effective lens position. So what we do, we find out
Yeah.
pre-RK values if you can get hold of that.
Okay.
We algebraically add to that the pre-RK refractive error. You got one value, let's say it's A. Okay. Now the
Okay.
current refractive error, you subtract it from that, and this can give
Okay.
you this value will be in the formulas. You will find this will give you the exact place effective help you to find out effective lens position. So basically,
Oh,
pre-RK values are basically required to find out effective lens position.
oh, okay. Okay.
So you are
Okay.
finding K values, but the reason is totally different. Otherwise, that logic in other procedures, since I told you this
Yeah.
is cut 90, we have cut the cornea to 90%. So
Yeah.
in other
Yeah.
refractive procedure, we say, and even in keratoconus, we say that anterior posterior wall ratio is altered, right? We say that.
Yeah.
That in
Yeah.
keratoconus, we are having problem because anterior posterior wall position is changed. Whereas
Yes.
in RK, anterior and
Yeah.
posterior wall both are altered proportionally.
Yeah.
So that logic doesn't apply here. So this is very important.
Yes.
So
Oh.
in biometry, you have two problems. You want to find out two K values. We are finding out through pentacam,
Hmm.
but still you want to find out pre-RK values so that you can find out effective lens position. If we do not have that,
Okay.
then there are many
Okay.
modern ASCR calculators. They can find out the most accurate, near accurate values. But you have to keep it in mind. There is one more thing,
Okay.
enough because RK is very important. I heard that many examiners are asking about cataract
Yeah.
surgery in RK because that age group is now having cataract surgery. So
Yeah.
there is another factor. So you are ensuring all these things, like you are taking into account all these things. There still can be some error. Why is that? Can you think about that? Something which varies in different days of the time.
Corneal
Patient has
opacity?
patient has diurnal variation in
Yes.
refraction. When gets up in the morning, she will have blurred vision. She will have more hyperopic shift. So can you
Okay.
think? Can you tell what's the reason, Asma or anyone, Heba, anyone?
Because when in the morning, when the patient wakes up, there is more there will be increase in thickness of the cornea, which with the passage of time, the whole day it becomes decreased. So there is a change in the
So
pattern.
basically, when there is edema, this will swell, and there will be more like separation of those incisions. So there is more flattening of the cornea. Okay. So in order to ensure that you are taking the right biometry, you have to repeat it multiple times in different times of the day. In the morning, you
Okay.
have to keep it in mind. Okay. So these are the precautions you have to take care.
So, ma'am,
Clear?
in the morning time, when the corneal edema increases more, is it because, but the endothelium is okay, right? So why the corneal edema will happen?
It's because of
the
ischemia. Because when you're sleeping, sleep-induced
yeah.
ischemia. So
Oh,
the
okay,
cornea
because of the
is
tear film and
so
closure of the lids.
that's why there is more flattening. So any operative precautions you have to do during RK to ensure good results?
Yeah, we should give incision in between these radial cuts.
One, good. Will you do corneal incision or scleral? Better to take scleral incision, right?
Okay.
So that you
Yeah.
don't disrupt. Yes,
Okay.
between those. Another thing, if during the procedure you notice some incision is gaping, what will you do?
We can suture it up.
We can suture it up. Okay. Let's say you're doing this procedure on this eye, and during procedure you are having lots of glare. Anything you can do to improve the visibility?
Yeah, we can put more
Viscoelastic substance over the cornea.
no, we can put just more this
Yes, viscous.
viscous on
the cornea.
Viscoelastic substance.
Viscoelastic, you can
Dispersive.
Yes, you can
Viscoelastic.
put viscoelastic material substance on the cornea to smoothen it up. Okay, so one more scenario. If this RK, if this is minimum, I think these are not very incisions. Sometimes there are 16 incisions, and cornea is very distorted. And no matter what you are doing, you are unable to take the proper care reading. What will you do then? How will you take? Anything you can do, improvise to improve your results?
Contact lens method, madam?
Yes,
$40 for contact lens.
Yes, correct. Okay, so I think we have done. So, what is the preferable choice of IOL in a patient with RK?
Single focal IOL. Multifocal, the patient might have a lot of glare.
Not might, they will definitely have the glare. So, multifocal is an absolute no. And preferably aspherical lens. That will be the better choice. Okay?
Aspherical lens. Okay.
So, do you want to do further question or is it enough?
Yeah, we can do. Okay.
So, a 41-year-old who is taking this question? Okay, there are just 3 more questions. I think we can do that. A 41-year-old high myopic woman has undergone an uneventful cataract surgery. Her uncorrected visual acuity is 6/60, but best corrected visual acuity is 6/9. Okay, I have forgotten to write. Okay, it improves to 6/12 with plus 6.50 minus 1.50 cylinder at 150 degrees, 6/9. Cornea is clear. IOL is in the bag. Her biometry is repeated, and we have found out that power of the IOL that was implanted, that was plus 23 diopters. Now is plus 23, but she was implanted 7.5 diopter IOL. What can be the reasons for this discrepancy in the biometry in this patient?
Yeah,
wrongly connected IOL, and the patient was not right. I mean, this could have been on various levels, like whether the patient was not named properly, and some other patient's IOL has been implanted. Then the other thing is like the patient was wearing contact lens, and the IOL calculation was done just after that, which could have given some discrepancies.
Good.
Then
yes.
Yeah, corneal rapid. And then what else? The patient was not, if it was done with the opticals, it's okay, but if it was done with ultrasound biometry, then there was either under or over pressure over the cornea while checking the axial length.
Good.
So the axial length was calculated wrongly.
Anything
And
else?
Maybe the wrong
the
eye.
A constant of the IOL was not properly checked, the A constant. And the other thing is siliconized eyes.
It can be because patient is high myopia, so you have to keep it in mind. And
Staphyloma.
Cephaloma, right? Cephaloma. That is very important. Okay.
And
all
we get the history of any refractive surgery in the past.
Yes, that is also possible. Very good. Very good. Very
Even
good. Okay,
severe dry eye sometimes gives wrong care reading.
Care readings. All these things are important. Raw human error, wrong biometry,
yes,
like swapping of IOL, missing
Yeah.
something, anatomical disorder like staphyloма or siliconoid eye. All
Yeah.
these things are important. Okay, so now this patient is here with you. What are the treatment options for this? What can we do for them?
IOL exchange since the power is more than 6.
But if lots of time has passed, let's say if patient presents after a year, then what other options can have? IOL exchange is definitely an option.
Corneal
Refractive
refractive
lasers. Refractive
Piggyback,
lasers.
piggyback IOL.
Piggyback
Back
IOL.
IOL, yes.
Piggyback.
And the
Piggyback.
refractive lasers doing
Con-
LASIK.
You can do that. Then you have to
Corneal.
justify. Who said laser procedures? Justify your like. Why would you prefer refractive procedures?
Yeah, because any residual refractive error, we have the option of not opening the eyes again. Can go for refractive laser. If the cornea, if the corneal thickness and everything is fine, we can go for refractive LASIK or PRK depending on the situation.
Okay, so plus 6.50 hypermetropia. Do you think this is correctable with Excimer, or you will have to leave some of the number in that case? You can do
Yeah,
that,
because it is
but
plus
it will be
number.
slightly difficult because in
Yes.
patient is myope, patient is already above 40. There can be patient has undergone cataract surgery. When you want to do hyperopic correction, the laser will be applied in the periphery of the cornea.
Yeah.
So,
yes.
and plus numbers can't get very good results more than plus 0.5, depending upon very good cornea. So patient may be suitable. If suitable, very good. Nothing like that. But if patient is not very suitable, then we have to go for the other options which other people are telling, which is piggyback IOL. Okay?
Piggyback IOL,
right?
yes.
So
Yeah.
So you have decided that you want to put piggyback IOL. So how will you calculate its power? Is there any difference, or you will just implant whatever refractive error you're getting? So what I'm trying to say, this patient is having plus 6.50 refractive error, right? With minus 1.50 spherical equivalent, it will be about like plus 5. So what will be is there any way to calculate what number of piggyback IOL you will implant into the eye? You don't know. For hyperopics, you multiply spherical equivalent with 0.50. Okay?
Yeah.
And for myopic, you use the same number. No change. And you just implant piggyback IOL. And are there any types of now you're going to implant another IOL, and patient says that previously she had monofocal IOL and she's having problem in reading. So are there any type of piggyback IOL which you can put and improve presbyopia as well? Is it simple piggyback IOL, or there are many options? Are there toric options? So there are many types available: monofocal, multifocal, toric, and all these are available. Okay.
Ma'am, we will multiply 6.5 with 1.25 in this case.
No, not you will take spherical. It's spherical equivalent. 6.50 plus half of cylinder.
Yes.
It will be 5.75, right? Plus 5.75, multiply it with 0.50, and that will be the number that you plant into the IOL. Okay. Okay. Any complication with piggyback IOL? Any problem you can have? Obviously, you're putting another IOL onto the previous one. So what problems can you have?
Pupil block, glaucoma, and the quality of vision will go bad because there are two lenses, one above the other.
Will it? Why? When you have
optical
right
aberrations
number,
can happen more.
There is nothing. There is no problem inside between the two lenses. Why will the quality of vision go bad? It won't. It's very good procedure, in fact, piggyback IOL. So main problem is pupillary block glaucoma, but the latest model, they do have a small hole in the, their models, their designs are such way that pupillary block glaucoma is not a big problem now. Otherwise, they used to do peripheral iridotomy used to be done. Secondly, the problem which can happen is because we are putting another lens IOL into the same bag area, at that angle, there can be rise in IUP. Okay, there can be pigment dispersion. There can be uveitis, there can be all the problems which are related to that. So piggyback IOL is the treatment.
Interlenticular membrane.
Okay.
Interlenticular membrane can be there.
Yes, interlenticular membrane that can also happen. Okay.
Ma'am, then what is the cause of discrepancy? There was one question. What is the cause of discrepancy?
The cause of discrepancy we have discussed. There can be many options.
Huh?
We have discussed many options. There can be many reasons. In myopic patient, there can be posterior staphloma. There can be siliconized eye. This can be human error while calculating, failure to take proper care reading if there are excessive dry eyes.
Yes,
right?
yes. Got it.
Okay. So this is the last question. Yes.
Ma'am, sorry. One question in the previous previous question is that can we offer a patient that one eye can be hypermetropic and the other can be myopic, so that one eye can see better vision in far and the other better in the near? Is this can be an option in this patient also?
Look, this patient has lots of discrepancy. Plus 6.5 is a huge number. Patient won't be able to see far and won't be able to see near. So you have to do something about that. Either remove the lens, exchange that, or do refractive procedure, because this is very bothersome vision, right? So that is the scenario more for myopic patient. So we are coming back. Yes. So this is another question. This is second last question. Describe this picture. And give your diagnosis.
I think it's cicatrizing conjunctivitis or limbal stem cell deficiency.
In the differentials can come the trachomatis scarring.
Okay.
Because can come Stevens-Johnson syndrome. There can be some capital burns or post scarring after that. And,
there can be neoplasia.
Yeah.
That, look, everything is possible. Important in the exam, important thing is you don't miss one very crucial diagnosis. So this can be everything. This can be like trachoma or everything, but you cannot miss OSSN because it's gelatinous look coming superiorly. You can see feeder vessels, so you have to think about that as well. You have to give that in differential. This is the main takeaway from that. Okay, so this is differential. So what investigation you will do to confirm
anterior segment OCT?
OCT,
the extent and the depth.
Yes.
This is the OCT.
This OCT shows the hyperreflective area that is confined in the epithelial area and not involving the stroma.
Anterior one third of the cornea. It is extending till that.
Yeah, but I think it's within the epithelium, isn't it?
It is anterior one third, starting from the limbal.
Listen, both of you. Whenever you see the OCT, the purpose of OCT is just like MRI or CT scan. It is giving you in detail every layer. Okay. In this part, have a look. This white outermost layer, this is epithelium. Okay.
Yes.
And this very fine white line is Bowman's layer. So this epithelium is coming here, and then it is abruptly increasing in size. You can say anterior 1/3. No, you won't say 1/3. You have to tell is it epithelial, subepithelial, or
Okay.
anterior stimulation. So this is a epithelial. It is more clear in this region. Here, this is
Okay.
coming epithelium, and then it is abruptly increasing in thickness. Can you see?
Yes. Yes, yes, yes.
Well-defined overall epithelium is thickened. It's
Okay, so this
hyperreflective.
is epithelial in growth. Yeah, okay.
So what is it? So this is epithelial. All this lesion is epithelial. You can see hyperreflective mass in the
Yeah.
epithelial region. So this picture coupled with this OCT, you
Epithelial
should be able
neoplasia.
to.
Squamous epithelial neoplasia.
So
OSS.
this is the
Yes.
accurate. Now I want your attention. First question, Tahmina, are you here?
Yes, I'm here, ji.
Tahmina, have a look at this OCT, and then I'm going to show you the OCT. This one. Can you see the difference in OCT? Here, if you are given a clear picture, this portion is epithelium, this hyperreflective part, okay? And this lesion is subepithelial.
Is subepithelial, yes.
Subepithelial. So whenever you are going for these things, you have to identify. Don't be vague, because the purpose of this is that you have to be very clear. It's epithelial lesion, subepithelial. Now, next thing, good. So we are done. So if this picture comes, these are pathognomonic signs of OSSN. Sorry?
October 8.
Huh?
So next thing, you have to see if it is involving Bowman's layer or not. You have to comment on that as well.
Yes, yes, Bowman's is involved. Yes.
Yes, this is a non-contact technology which can tell you accurately that whether it is what lesion it is, what is the extent, and you can tell. Okay, so we have established that this is OSSN. So what will be our so what to do next? Just in OCT, you can't make a diagnosis, right? You have to confirm it further.
Yes.
So what
histopathology is the first thing. Yeah.
And what will you look for?
We look for the cells that is at hemotoxin eosin staining will show the type of cells.
Thickening of the epithelium. Thickening of the epithelium. Hypertrophied.
Yes, and you will find atypical cells. You will find basically.
Atypical cells, yes. Atypical cells.
What is the treatment? This patient is here with you. So what is the treatment for OSSN?
Excisional biopsy.
That is the gold standard. You have to remove. Any other thing you can do? Like excisional biopsy, you send for histopathology. So will you plan?
Yeah.
So the gold standard is surgical excision, right? So if patient is not willing or due to some reason, patient doesn't want very invasive procedure, what else? What alternative options do you have?
Sometimes give some mitomycin drops also. Sometimes it is
topical mitomycin.
Yes,
topical mitomycin drops is given, immunosuppressant.
Yes, 5-fluorouracil can be given.
Yeah.
There is another interferon alpha 2b. This is also given topically and in the around the lesion. All these things can improve. Okay.
Okay.
I think that is enough. So it's very important when you are describing OCT. There are just few conditions which you have to memorize. You can simply memorize that. This is the last question for today. Okay. So we will. This is also important, and then we will be done with it. A patient presents with post-operative astigmatism despite having toric IOL implanted. Okay.
Yeah.
What can be the cause of?
Movement of the axis, ma'am. Movement of the axis.
Rotation of the IOL.
No, when we are when we do with the cadisto or when we are marking the axis, that time after that maybe with the capsular fibrosis the axis could have been changed and that is the result.
But there can be some things before that, like you have to tell
the corneal the corneal
but irregular astigmatism. Because I think only regular astigmatism can be corrected with the toric IOL. If it is
let me rephrase my question. Are there
Incision
some
segment.
patients which are not suitable for toric IOL while selecting the patient?
Yeah.
Which one?
Corneal
Ma'am,
opacity.
who the keratoconus which cannot be corrected by the by the RGP lenses, they will never be happy if we do toric IOL
So
because
there,
of
if there
aberration.
is good any kind of ectasia, okay, not
Ectasia,
only
yes.
keratoconus, ectasia
Yes.
with irregular astigmatism. What else? Anything in examination you see and you say no, this patient is not suitable?
Any
Zonular?
corneal opacity.
Any corneal opacity, yes.
Yeah, any
Zonular
corneal
license
or
weak zonules,
Yeah.
With lens in
right?
lens in the
Yes.
Okay, so next
lens not in the back.
one is poor selection of the patient, right? Second
eccentric
is
cone.
anything in the power calculation error in IOL power calculation. What are the factors? You just saying that there may be some mistake in there are two factors. When you are calculating, choosing the IOL, you have to calculate two things. One is IOL power, and second is its axis. Okay. So can there be any factor which can lead to wrong IOL power calculation in toric IOL? Like we have discussed before.
Yes, like corneal ectasia, dry eye, yes. And
Glaucoma.
eccentric cone. Yes, eccentric cone.
Okay.
Yeah.
Or you haven't taken like axial length while measuring axial length, error there. Then the other factor is it's a toric IOL. So the other factor is you have some problem in choosing the axis of the toric IOL. Wrong calculation of axis. What are the factors which can do that? What are the factors? We just discussed everything in this
be
presentation.
miscalculated. Yes, the axis can be miscalculated in the dry eye, severe dry eye. It can be miscalculated in the cases of keratocorneal ectasia if it is irregular.
So Arshi, I want all of you to register one thing. Whenever you are talking about error in calculation in the K readings or this, there is one crucial thing you have to consider. Like when you're talking in terms of astigmatism, when you say that failure, this ectasia, basically we are talking about more about discrepancy between anterior and posterior wall.
Yes.
Keratoconus or any sometimes it's not
lucid or
keratoconus,
anything.
but there are some elevations in the posterior wall, and if you do not take that into account, that will lead to unexpected astigmatism.
Yes. Okay.
So always mention that failure to take into account the back wall elevation. So either you use multifocal IOL or toric IOL, you always do pentacam. And while doing pentacam, in addition to other things, you are looking at the back walls. So this is very important. So although you are saying correct, everything correct, but you have to be very clear that you are wrong axis either because of failure to take into account back wall elevation. What next? What other things in biometry?
What other things?
Effective lens position. Look, when we use IOL master, it automatically does all these things. It is taking into account, it is measuring AC depth, it is measuring white to white, it is taking accurate K reading, and it's doing all these things. You must know that what are the difference from conventional in that, which is giving good results. So not only K readings, it measures interior chamber depth, and we just discussed that AC depth is basically more associated with effective lens position, which is important. Okay.
Position. Yes.
So AC depth and all these things. Anything else? Unsatisfactory results.
We should when we are doing manually when we are doing IOL calculation, we should never do axial length first and then keratometry when we are doing separately, because it will lead to changes in the K reading. When we are doing the axial, we can make
perfect.
So
anything else?
Toric IOL can correct only, I think, till minus 2.5 till 2.5 or 3 diopters. Above it, if it is 4 or 5 diopters of astigmatism, it cannot be corrected by toric IOL.
It cannot give very good results. Yes. So during procedure, what we have done, So now we come to those things which you were mentioning first. So always go step by step. Pre-op assessment, what are the factors you may have missed during biometry? What are the problems you have done? Now, when you are starting the procedure, all you were saying, what were those things? Say again so that we complete this thing. So wrong markings.
Yes, wrong marking. Yes.
Failure to align with those markings. That is another thing. Another thing. Another very important thing. What next? You have marked next step. You have to do.
These markings should be done while the patient is sitting.
Yes. Perfect. Okay. What next? Now, another factor, very important factor, which may have caused this problem.
Because
after that, there was a tilting of the lens. After that, when we put pilocarpine or myostat to, you know, to
that can happen.
Make the pupil small, that time it can.
If while planning, you failed into taking into account the incision-induced astigmatism, that can also affect the astigmatism, right?
Yes.
So what is the
so we have to take it at the steep curvature. Yeah.
Yes, you have to take that into account. Where will you put incision? What will be the size? Otherwise, you generally, if you're not, like, you just pick up the knife and you can sometimes enlarge the incision, right? And that gives astigmatism. I mean, you can get away with that, but not with Toric. So what is the size of incision, which won't cause significant astigmatism? Up till what?
So this is I think up till one diopter can be induced by the surgical incision.
No. What should be the size of corneal incision, which to avoid surgically induced astigmatism?
Not more than 2.5 mm.
Yes. If it is more than it, let's say 3.2, how much astigmatism you can expect? Like, if you have enlarged it to 3.2, it can cause 0.5 to 0.75 astigmatism, right?
Okay.
Yeah. Okay. So during procedure, what you fail to align, that one thing you said, that you put pilocarpine and there is rotation, and another important factor, if you do not remove viscoelastic properly.
Yes, if viscoelastic is not removed properly, then it can.
So having done that, now patient has astigmatism. If patient, if it is immediate post-op period, then you can do, like, you can rotate, you can manipulate that, all of that. But lots of time has passed, and now whatever done is done. What are the options you can do to correct astigmatism?
This will be again the lenses, RGP lenses. First the glasses, we'll try with the glasses. Then again the RGP, if it is not correctable, we can give RGP lenses. If it is not correctable, sometimes we can go for refractive lasers.
Why not refractive procedure before that? Like, you can do that.
Adequate incision in the steep axis.
You can do refractive procedures, right?
Yeah, RGP relaxing incisions also we can do. Yes.
You can do. What else? What else you can do? You can give some relaxing incision.
Relaxing incisions, yes. Yes.
You can
opposite
give single
to the
and sometimes if it is too steep, you can give double relaxing incision. Okay.
Okay.
And
these relaxing incisions are given at the level of the steeper curvature.
Yes, at the steepest curvature.
Yeah. Okay. Yeah.
I think that's enough. Well done, all of you. All of you have done very well. All you have to do is just practice how to reply concisely, which all of you have managed very well.
Thank you so much.
Thank you, madam. Thanks a lot. More information. Thanks a lot. Thank you.
Thank you very much.
Thank you.
Okay, Dr. Kochik,
Thank you, ma'am. Thank you. Good day, ma'am.